Thank you, thank you. I'm Dr. Don Blanton. I'm board certified in internal medicine and emergency medicine. My career has been in emergency medicine for more than a quarter century now. And for the past 2 years, I've been practicing going to medical centers across the country and helping them and their medical staff negotiate all these changes that are going on in the healthcare system that you've been reading about in all the papers. We're going to talk about ICD-10, that's coming October the 1st, but we're going to talk about so much more than that because we need to understand what's happening with those codes after they leave the hospital. We're going to talk about risk adjustments, quality, cost efficiency analysis, the changing reimbursement environment, and conditions as they are defined in the literature with an emphasis on the severities of illness and the transition between those because they're important in getting us credit for the severity of illness of the patients for whom we care. ICD-10's coming October the 1st. It was delayed a year ago. The AMA has even dropped their opposition to it. At first, there was a big hoopla about the increase in number of codes. We're going from about 15,000 diagnostic codes to almost 70,000. And Medicare, not the privates, but Medicare has announced that they're going to be a little bit forgiving during the first year. If we make simple errors in coding, they're not going to hold that against us. Not sure what Blue Cross or Aetna or United or any of those are going to do. One of the reasons the hoopla about the vast increase in numbers of codes died down pretty quickly is half of them just relate to the musculoskeletal system. A full third are due to the fact that they've added laterality left and right. You add left, you have to add right. Then for many things there are a bilateral option, and then for many things as well there's an unspecified option when we don't signify left or right. But we want to exercise concern about that because we think the payers, if they get an unspecified code, but we know if it's a left side or a right side, that it's an excuse for them not to reimburse the claim. So we want to be cautious about that. This is a table that was produced by Medicare, published in JAMA, and it tracks the evolution of where the reimbursements for healthcare is going to go. We've been in fee-for-service, but fee-for-service is dying and it's going away pretty quickly. Right now, they're beginning to base reimbursement on quality and cost efficiency assessments, and they're doing that through the physician value-based purchasing modifier. But all of these methodologies are based first on the ICD-9 codes and ICD-10 codes that our documentation is translated into. So why do we care about all of this? Well, we're being graded for quality of care and cost efficiency of care, and those assessments have been available to insurers for a while. I don't know if you noticed, about a year and a half ago, United Healthcare dropped thousands of doctors off their provider rolls, just made them out of network because they were deemed not to be cost efficient. They may or may not have been. We'll see how that could be in just a little bit. And these assessments are going to become increasingly available to the public. Anybody in the globe with a computer and an internet connection can get access to these scores. And these assessments for quality, cost efficiency are going to affect reimbursements not just from Medicare but from privates as well. So how do they get this information into the system? From our office records, they come from the physician quality reporting system, and from hospitalized patients, they get this information off of billing records. They're not looking at the charts. They're not talking to your patients, each of whom loves you, I'm sure. They're getting this information from the charts. Every diagnosis, principal diagnosis, every secondary diagnosis, diabetes, hypertension, hypothyroidism, gets an ICD-9 code and it goes on this list. The longer that list is, the more complex that patient looks. The more serious those conditions are that get coded, the more severity of illness the patient is described to have. It also has the length of the hospital stay and how much we spent to accomplish that care. This is the information that they're using to judge us for quality of care and cost efficiency of care. This is a screenshot from Medicare.gov. Right now, it's basically just an index, a directory of name, address, office, phone number, but soon these quality cost efficiency scores are going to be published on this accessible website. There's also a more detailed and confidential report called the Quality Resource Use Report, the QRUR, that's based on this same data but much more detailed, and they're going to grade each of us as high, average, or low for both quality of care and cost efficiency of care. Now, there are, in the handout, in the appendix, there are instructions on how you can get your own QRUR report. People in the mega groups of more than 100 members, their reimbursements are being adjusted already. That started at the start of this year. For folks in groups less than 10 members, That's going to start in 2017, but they look at data from the previous 2 years. So even those of us in the smallest groups, they're looking at those billing records now to accumulate this data. So we still have a good bit of time to tweak our documentation to make it more accurately represent the patient's severity of illness, and that's kind of what we're going to spend the bulk of our time talking about. But it's going to be implemented for everybody in 2017. And if you are deemed to be a high quality and low cost physician, then they'll boost your reimbursement 4%. But if you're deemed to be low quality and high cost, they're going to dock you 4%. And these are the diagnoses that they're going to be looking at to make these determinants: COPD, emphysema, coronary artery disease, heart failure, and diabetes. Now, that having been said, at the start of 2018, they're going to change the system to what's called the merit-based incentive payment system. And the PQRS, the Physician Quality Reporting System, the data in, the value-based purchasing modifier, the adjustment of reimbursements back, and the meaningful use of electronic health records as separate programs are going away. They're all going to be consolidated into the merit-based incentive payment system, or MIPS. Within that, each of us is going to get a grade between 0 and 100 in each of these 4 areas: quality of care, meaningful use of electronic records, use of healthcare resources, in other words, how much we spend on testing to accomplish the care we provide, and activities undertaken to improve clinical practice. So at the end of 2017, we've got the 4% carrot and the 4% stick, but by the end of 2021, which seems like forever from now, but it's only 6 years away, NASA has announced they plan on building a moon base by then. The law states that our reimbursements can be boosted by not more than 10%, but they can also take as much as 9% away. So if you also have an office practice and the overhead is about 50%, this would mean a loss of take-home pay of 18%. We don't want to be in that group, and you're not going to be, because we're here today learning how this works. Just in the way of background information, some terms: the principal diagnosis is that condition established after study, may not be apparent on the front end, that condition established after study that's chiefly responsible for occasioning the inpatient admission to the hospital. In other words, it's why they couldn't go home. It's why they couldn't spend the day in observation status and go home. So it may not be their pneumonia that makes them have to be an inpatient. It may be the fact that they're septic. It may be the fact that they're hypoxic and in acute respiratory failure. Secondary diagnoses, also comorbidities, is anything that meets any one of these criteria: something that requires clinical evaluation, therapeutic treatment, a diagnostic procedure, anything that extends the length of the hospital stay or requires increased nursing care or monitoring qualifies as a secondary diagnosis. And then procedures. So it's these 3 elements, the principal, secondary diagnoses, and procedure, that combine to make the hospital's DRG that determines how much they get reimbursed. We used to not care about the hospital DRG because that was the hospital's DRG, and we billed CPT, didn't make any difference. Well, now it makes a big difference because it's these same parameters that they're using to judge us for quality and cost efficiency of care. And when we get to bundle payments, which is coming in January for certain orthopedic procedures, even to Pomona Valley, the hospital's reimbursement and the physician's reimbursement is going to come out of the same bucket. And so we need to start paying more attention to these sort of things. The concept of risk adjustment, that's why a life insurance policy for a 16-year-old costs less than a 60-year-old that smokes 3 packs of cigarettes a day. But we're interested in risk-adjusted outcomes. And when we hear the term risk adjustment, or you're reading the literature that talks about risk adjustment, just think graded on a curve. We all know what that means. We're being compared to other people, other patient care of similar parameters. So the risk-adjusted outcomes is comparing observed outcomes to expected outcomes. And we can look at pretty much anything: mortality, length of stay, how much we spend on drugs, imaging, post-op infections, readmission rates. So when we look at observed versus expected, and we get risk-adjusted outcomes and compare that to how much we spent to get there, you get the concept of cost efficiency. And these are the basic modalities that they're using to judge us. So the observed outcomes are easy enough to identify. That's what's on the medical record. That's what most quality improvement programs have been aimed at. But where do they get this group of patients to compare my care to? Who are these people? Well, these are other physicians' patients with similar demographic characteristics, similar principal, secondary diagnoses, and procedures that are deemed to influence whatever we're testing. So if the height of this bar represents my patient's true, complete, total severity of illness, complexity of illness, but by virtue of how I document, the coders can only code and thus report to the world, my patient is this sick, between here and here we got a problem. And it's this documentation gap that's the difference between my patient's true severity of illness and how it's represented, and that's determined entirely by the language I use on the medical record and the coder's ability to translate that into ICD-9 codes and ICD-10 codes for which we get credit. So the pool of other patients to whom my care is compared depends not on how sick my patient is, but how sick my patient looks on paper to the coder. And that depends on what I write in my emergency medicine note, what's in the H&P, the progress note, op note, and most importantly, the discharge summary, because that's the last word of the physician of record on how the patient presented, what we identified, how we intervened, how they responded, and how we expect the post-hospital course to go. So when we fill this gap, we'll reduce, with the goal of eliminating downcoding of DRGs, just abject denials of payment because we did not establish the medical necessity for the procedure or services that we provided. And medical necessity is, in the eyes of the payer, not in the eyes of us physicians. Our quality portrayals will be accurate and our cost efficiency portrayals will be accurate, and we'll be a long way toward getting the specificity required for ICD-10. Now, the translation of our medical language that we use with each other, that we use on the medical record, into these processing languages for billing, reimbursement, and statistical analysis, quality analysis, cost efficiency analysis, is not very smooth sometimes. There are words that we use frequently for which we just don't get any credit. We need to understand what some of those are. So the goal of all of these methodologies is to communicate the patient's severity of illness. So we're going to understand these a little bit so we'll understand how the system works. In the Medicare severity diagnostic related groups, these first two are for inpatients only. The Ms-Drg, the Medicare Severity Diagnostic Related Group, used obviously by Medicare, but also most of the privates use this methodology. The APR-DRGs are used by Medi-Cal, and the HCC's hierarchical condition categories are extremely important. They accumulate ICD-9 codes not just from inpatient admissions, but from outpatient diagnoses as well. And we're going to talk about all of these in a little bit more detail. But first, in the Ms-Drg system, the principal diagnosis is what it is. All the secondary diagnoses have attached to them a descriptor of the severity of that secondary diagnosis. And it's a three-tiered system that revolves around this term abbreviated as a CC. The two C's stand for, one is a comorbidity, a secondary diagnosis. Anything on the front end of the signing of the inpatient order, everything they bring with them to the hospital, all their chronic conditions, hypertension, lupus, heart disease, diabetes, emphysema, and the acute things like pneumonias, strokes, heart attacks, fractures, everything that we identify before the inpatient order is written is a comorbidity. Things that arise anew after the inpatient order is written are just called complications to distinguish them as happening after the inpatient order is written. And an MCC is just a major one of those. So the three tiers are highest level of severity, an MCC, major comorbidity or complication, a CC, and then neither one. Those are the three tiers. So terms that fall in the neither one category, we get no extra credit for at all. And that can be problematic, which we'll see in just a moment. In the APR-DRG system, all patients refine DRGs, and it's a bit more refined because there are two categories, severity of illness and risk of mortality, and within each of these there are four options, and they're reflected in a number scale from 1 to 4. 1, not very sick at all, that's as low as it goes, there's no 0. 1 is not sick, 4, very, very sick. And the severity of illness and the risk of mortality numbers don't have to be the same. You can have a pretty profound illness that has not much of a risk of mortality, so the numbers can be different. In the Hcc methodology, that severity of illness is represented in relative weights. Every secondary diagnosis has a little fraction of a number assigned to it, and you add all those up together to get a total number that represents the patient's severity of illness. And these are also called outpatient DRGs because they help fund outpatient as well as inpatient parameters, which we'll see in just a moment. Now back to the Ms-Drg system, the three categories of no increased relative weight assigned, some increased relative weight, and big increased relative weight I selected these two terms specifically because in my more than a quarter century practice of emergency medicine, these were two of my favorite terms. I used them all the time. Altered mental status and unresponsive. And if I used those terms with you over the phone, you'd know what I was talking about. But we get no credit for these terms. And after it was explained to me, I've come humbly to understand that a mental status is like a nose. Everybody's got one. Altered nose is not a good diagnosis. Altered mental status gives you no clue as to why the mental status is altered. But if we can describe it as a psychosis or a delirium, we get some increased relative weight credit for that. If they're in a delirium because their sodium is 110, well, that's a metabolic encephalopathy, and we get credit in this column for a metabolic encephalopathy. Same patient, same doctors, same nurses, same interventions, same length of hospital stay. We get big credit, we get no credit. And unresponsive, that's your daughter when she's mad at you. You call home and you hear, our daughter is unresponsive. Well, what's she upset about today? You call home and hear she's in a coma, that's different. So we get big credit for this, no credit for this. Heart failure. When I was born and we admit somebody with an exacerbation of heart failure, the diagnosis was just CHF. Everybody knew it was worse. They needed to be in the hospital. The coding system now makes no such assumptions. It makes no assumptions at all. It's based only on the terminology that we use in the record. Because they had heart failure last week, they weren't in the hospital. What changed? Well, they have an acute exacerbation of heart failure. And for heart failure, they want to know if it's systolic or diastolic or combined. Well, this is not even the terminology that the cardiologists like to use. They like to use heart failure with reduced ejection fraction. And that's fine, they can use that. There's no code for it, so it goes over here, no credit. I mean, they get some credit, but no increased relative weight credit. So we have to use systolic, diastolic, or combined. And if they have this condition, but they're in the hospital for something else, we need to note that they have this because we still get extra credit for it, even though it's stable, not decompensated, not an acute exacerbation. Symptoms, we get no credit for. So when we describe acuity, why is it different from last week when they weren't in the hospital? We get big increased relative weight credit for that. In the hierarchical condition categories, the HCCs, these codes accumulate from inpatient and outpatient diagnoses, and these are particularly important to us because this is the methodology that they use to adjust our reimbursements. This is the methodology that Medicare uses to establish the average cost per Medicare beneficiary, and this is what Medicare uses to fund ACOs, Medicare Advantage programs, and independent practice associations, and all those are big in California. This table looks busy, but it's all about one patient, a 65-year-old female, and these are the fractions of relative weights that accumulate, that are assigned to the different secondary diagnoses. And she's got a lot going on in her life. She's got breast cancer, metastasized to bone, she's malnourished, and has pressure ulcers. But you notice these are based on calendar year codes. These expire at the end of every calendar year. The motivating force behind that is to make sure that these patients are seen by somebody at least once a year so we can try to stay ahead of things. So New Year's Eve, Ryan Seacrest is in Times Square, the crystal ball drops, Happy New Year, oh yeah, your Hcc codes are gone, you have to renew them. If that does not happen, we only get the base demographic rate for the patient. And so this is a 65-year-old female, relative weight of 0.3 and change. You multiply that by the reimbursement rate, which is around $10,000, up or down based on geographic variances, cost of living and stuff. So we've got $3,000 that goes into the kitty to take care of her and all the other patients in the ACO next year. But let's look at the relative weights to these other things. She's got breast cancer. That relative weight is 3 times her baseline. That it has metastasized to bone doubles it yet again. She's been sick, so she's malnourished. Big increased relative weight for that. Malnutrition is way underdiagnosed at almost every hospital in the country. Pressure ulcers, stage 3. This relative weight, stage 4, 2.4. So when we document all of her diagnoses, we've got almost $60,000 in the kitty to spend on her care next year. So when we get consulted to be involved in her care and we're dipping our ladle into the bucket of reimbursement, I want to be dipping into this big bucket, this deep bucket down here. Now, you'll notice history of breast cancer for relative weight has goose eggs. Well, why is that? Well, that highlights the ambiguity of the phrase history of that we were taught when we were medical schools, that we've taught students and medical students behind us. I have a history of strep throat, but I do not now have strep throat. I have no sequelae of strep throat. But when we say somebody has a history of COPD or diabetes or lupus, we're communicating they still have that because those things don't go away. Well, again, the coding system makes no such assumptions. When they see the term history of, it tells them, yes, they had this, they don't have it now, and we're not doing anything to treat it at all. So we don't get any resources because we're not treating it at all. So history of, the coding system says you had it, you don't have it now, and you're not doing anything for it. So if somebody has breast cancer, lumpectomy, radiation therapy, they're on tamoxifen for 5 or 10 years, even though tamoxifen is not an antineoplastic, as long as they're being treated for that condition, taking medicine for that condition, they have the active disease and we code that. Once they're not taking anything, breast cancer is important enough to keep on the problem list. We don't want to forget that because sometimes it flares back up. So we keep it on the problem list, but we don't get any credit for it. Now, some electronic health record systems have, scroll downs and a column that says history of, and we may think, history of this, history of that, that we're populating the problem list when actually we're telling the coding system they don't have this, they don't have that, they don't have that either. So history of, and I still find myself, even after years of doing this, saying history of when I mean they actually have it. So this is a table of Hcc codes and their relative weights for people in the community and people who are institutionalized. Sometimes they're different for nursing home patients. There's not an Hcc code for everything. There's not one for these diagnoses. There are almost 70,000 ICD-10 codes coming. There's only 70 Hcc codes. There's not one for things that are very short-term duration, that are not heavily healthcare resource-based. There are not codes for things that are chronic and long-term duration that are not actively resource utilizing. For example, atherosclerotic heart disease of a native coronary artery, if you're not having angina with it, if it's just there, it can be there for years without having to use much resources. So there's not even an Hcc code for that. But if we have somebody on chronic nitrates, what's one of the reasons we put somebody on Imdur, Nitrobid, that sort of thing, NitroPaste? Well, if they're having frequent breakthrough angina and they're using sublingual nitroglycerin a lot, so we give them a long-acting nitrate, they have the condition of angina. We're using that medication to treat that condition. Their symptoms may go away, but as long as we're using that medicine, that's the condition we're treating. So if they have unstable angina, any form of active angina, there is a code for that. And remember, the Hcc methodology is the one they're using to grade us and readjust our reimbursements for. So this forces us to go down that medication list and make sure we understand exactly what condition each one of those drugs is treating so we can give ourselves credit for that. Sometimes it's very obvious. If I have diabetes and I'm taking glyburide and my blood sugar is normal, my hemoglobin A1C is normal, do I still have diabetes? Sure, of course. Same thing with hypertension. My blood pressure is normal, my LV size, function, ejection fraction is all normal, but I still have hypertension. Same thing with seizure disorders. And seizure is a symptom. Seizure disorder is a condition. We get credit when we write the term seizure disorder or epilepsy. We get no credit when we just say seizure. Not so obvious are, as we talked about, treating the condition of angina with long-acting nitrates. The fact that we're using long-acting nitrates, their active angina may go away, but we're still that's why they're on that medicine, so we can still diagnose that condition. If somebody has atrial fibrillation and we start them on an antidysrhythmic like amiodarone, as long as we're continuing the medication for the atrial fibrillation, even if they revert to normal sinus rhythm, as long as they're taking amiodarone due to atrial fibrillation, controlled on amiodarone, we still get to diagnose the atrial fibrillation, get credit for that, even though they're back in normal sinus rhythm. In ICD-9, we don't get any increased relative weight credit for any form of atrial fibrillation. In ICD-10, we get increased credit for persistent atrial fibrillation, which is AF that lasts longer than 7 days. So paroxysmal, less than 7 days, short term, no increased credit for that. Permanent atrial fibrillation, when we've just given up trying to convert their rhythm, but now we just control, we anticoagulate and control their rate, we don't get any increased relative weight for that, despite the fact, controlling their anticoagulation is probably harder than anything else. We still don't, those are the rules. And, but for persistent atrial fibrillation that we're treating that persists beyond 7 days, or we treat beyond 7 days, we do get increased relative weight for that. So even if they go back into normal sinus rhythm, if we're still using the medication to treat that condition, we on the problem list, atrial fibrillation controlled with amiodarone or on amiodarone. Now, if somebody comes in, new onset atrial fibrillation, you put them on amiodarone, and on hospital day 3 they convert, on hospital day 4 they go home, hadn't been 7 days yet, so it's not technically persistent yet because that's the 7-day threshold. Can you call that persistent atrial fibrillation when they go home? I think you could, because your intent is that they're going to stay on the amiodarone for 3 months or 6 months, way beyond the 7-day threshold. So I think you could legitimately call that persistent atrial fibrillation, even if they've gone back to sinus rhythm, if you continue the medicine. Antiretrovirals as well. If anybody has ever had an age-defining illness or an age-defining CD4 count, they're going to be on antiretrovirals for the rest of their life. And then AIDS has just become another chronic disease. They need to be careful crossing the street because they're more likely to die getting hit by a bus than dying of AIDS, as long as they take their medications. So when we see them back, they may be totally and completely asymptomatic, but if they've ever had an age-defining illness or CD4 count, as long as they're on that medication, it's AIDS controlled with the antiretrovirals, and that makes it a secondary diagnosis at the very highest level of severity, the MCC, compared to nothing. If somebody is just HIV positive and has never had an age-defining symptom, age-defining illness, or an age-defining CD4 count, the state of California even prohibits us from coding that. We can't report that if they've not had an age-defining incident. But once AIDS, always AIDS for diagnosis and coding. So we're starting this in October the 1st, and by law, every diagnosis, regardless of the location where it's made, inpatient or outpatient, has to be coded in ICD-10. This is not part of the Affordable Care Act. This is the HIPAA legislation from 1996, what was then called the Kennedy-Kasselbaum Act. Now, in ICD-10, they've separated out the procedure coding system. That won't affect you as physicians. Every procedure you do in the office is billed CPT, outpatient surgery centers, even in the ER setting when they go home, same-day surgery, all CPT only. The procedure and the facility fee is billed in CPT codes. Only if the patient becomes in inpatient status does the hospital then use the ICD-10 PCS coding system to report it, with the caveat that if they have a procedure done within 3 days prior to that inpatient admitting order, then the hospital is required to code it and bill it in ICD-10 PCS. But CPT doesn't change. We use CPT to bill in the office, bill in the hospital. That doesn't change. The only thing that will change over time is how much money we get back based on those CPT codes. Now, every time we order outpatient testing, whether it's blood testing or imaging, we have to submit with that request or that order the ICD-9 codes that justify the medical necessity to the payer for whatever it is that we're ordering. And again, medical necessity is in the eyes of the payer, not in our eyes. So we need to be sure that we use the right codes to justify that. Now, this is an example of home PT testing on somebody that's on an anticoagulant. So in ICD-9, there's one code for that, but in ICD-10, there are 5 different options. So what the payers will do when we submit that ICD-10 code, they'll backward map this to the ICD-9 code to see what they paid for in ICD-9 to be sure we get compensated for that. I'll say this about this general equivalence mapping table. We have this available to you for download from the hospital's dashboard, and it's got every ICD-9 code and its description, and every ICD-10 code, and whether it's an exact match or an approximate match, or there's so many new options in ICD-10 you really need to look at a table. Don't print this table because it's like 2,500 pages long. In office encounters, there are 2 different codes when you do an examination and don't find any abnormal findings versus when you do find abnormal findings. Now, it's totally agnostic as to what those findings are, but if you find something that's abnormal, then there's different code than when you don't. So that just needs to be obvious in your notation. In ICD-9, 5-digit code, ICD-10, 7-digit code, vast increased room for expansion. Important concepts in I-10. Acuity, we talked about, what's different about it this week than their chronic condition last week when they weren't in the hospital. Increased anatomic specificity. In ICD-9, there's neoplasm of the lung. In ICD-10, it's left, right, upper lobe, lower lobe, overlapping lobes. Left and right, we got that. Episodes of care. These don't apply to every diagnosis, just those related to trauma, not our bailiwick, or toxic events related to medications or other toxic chemicals like carbon monoxide and that sort of thing. The initial code, and it's just the last digit to the 7-digit code, the initial codes describe the active treatment phase, which would be the course of hospitalization. Subsequent codes are during the healing phase. And then sequelae codes are after the healing is totally complete. If something arises that relates to the original incident, then that relates that. For example, if somebody has a severe burn and then has a contracture that needs to be released, that relates it to the original injury, then there are new codes for everything else that goes on. But again, only for trauma and medication and toxic issues. Combination codes, the fast food industry is way ahead of us on this. You go into McDonald's and order number one, you know what you're going to get a list of. They don't have to write it down every single time. 2 all-beef patties, special sauce, lettuce, cheese. They don't have to do that. We're catching up on that. Present on admission identification, very important because Medicare has a list of things which are listed on a table in your handout of things that when they occur after the inpatient order is written, like DVTs, pulmonary embolies, if somebody falls out of the hospital bed and breaks a bone, that was not present on admission. If they happen during the course of the hospitalization, even though they may have a secondary diagnosis, increased relative weight at the CC level or even MCC level, if it's a hospital-acquired condition, we don't get that credit accrued to our quality of care issues. The hospital does not get that increased relative weight that goes to a higher DRG. Everybody just has to eat that. So it's very important if somebody is sick and develops parameters of sepsis that if that nomenclature is used on hospital day 2 or 3, that we overtly relate it to that the infection was present on admission. Same with pulmonary emboli. If somebody is hospitalized for an episode of syncope, and it isn't until hospital day 2 that we do the CT angiogram of the chest, identifies the PE, clearly explains the syncopal episode, but if they have a PE during the course of hospitalization that's not present on admission, that's a rot row. We don't want that, so we need to note that it was present on admission. Cutaneous ulcers, pressure ulcers, we get dinged if there's stage 3 muscle necrosis or stage 4 bone necrosis unless they were present on admission. Even if somebody has a stage 1 pressure ulcer on admission that gets worse, we don't get dinged if we note that it was present on admission. And stage 1 is just, red skin that doesn't blanch when you press on it. So we got to be really careful about that. So we talked about chronic systolic heart failure. When we name the acuity, the functionality, we get increased credit for that. Acute, we get big credit for that. Acute on chronic, we get big credit for that. But when we just go old school and just say CHF, we get no increased credit for that. And the purpose of this table is to identify that just by throwing the word acute in front of anything doesn't always get us increased credit for it. Acute bronchitis is just not that resource intensive, so we don't get any increased credit for that. I mentioned malignant neoplasms of the lung, left, right, lower lobe, overlapping lobe. But when we don't give any increased anatomic specificity, we lose all credit for that at all. And tumor and neoplasm are terms we get credit for. Mass is a term we get no credit for. That's just where they drew the lines. We mentioned these episodes of care codes, and this is to remind you that these ICD-10 codes are based on inpatients and their phase of healing. There are CPT codes for the initial care of somebody that's new to you or new to your practice. That's different. That's not what we're talking about. These are inpatient ICD-10 codes that relate to the patient's phase of healing, not the physician's encounter. Now, in the area of pneumonia, simple pneumonia versus complex pneumonia, the coding system calls complex pneumonias respiratory infections and inflammations, but you notice the relative weight of these is 60% higher than the simple pneumonias, the pneumococcus, the mycoplasma, the H flu. So when we see somebody that may qualify for what we call a complex pneumonia, we want to be sure we identify it as such. Gram negatives, Legionella, Pneumophila, staph, whether it's methicillin resistant or sensitive, TB, fungi, aspiration pneumonia, which is probably the most common that I've seen in my practice, empyemas, lung abscesses, and mediastinitis. So all of these are much more highly weighted than simple pneumonias. Risk factors for higher weighted pneumonias. Now, in ICD-10, interestingly, the codes are based on the organisms that cause the pneumonia. We hardly ever know what organism is causing the pneumonia. Most of the time we don't know. So how do we get credit for that? Well, we're sort of telling the world what we think is causing pneumonia by the antibiotics that we select. If we think it's community-acquired pneumonia, we'll use Levaquin or Urosepsis and cover the atypicals with Zithromax. But if we think somebody has aspirated, then we want to cover for those anaerobic oral flora, so we'll use something like Unison. If we think it's MRSA, we'll use this or Vanc. If somebody's been on steroids forever, we think they may have Pseudomonas, then we may use something that's anti-Pseudomonal. So let's say we never find out exactly what the organism is. Well, we can use that uncertainty in the inpatient environment if we note the uncertainty at the time of discharge. So we can use terms like probable aspiration pneumonia, suspected Pseudomonas, likely Pseudomonas, and the coders can code that as if it were established in fact. But it has to be documented at the time of discharge, preferably in the discharge summary, on the discharge note, the last progress note, or the discharge order. And this only works for people in inpatient status. Doesn't help us in the office. We still just have to go with symptoms. Doesn't help us if somebody's just in observation status. But if they're in inpatient status, then we can use these qualified diagnoses and get credit for it at that higher level. Now, and it doesn't just have to be pneumonia. When somebody comes in with a DVT or a PE and we put them on anticoagulation, that's not affecting the clot unless we use a thrombolytic like TPA. We're treating the hypercoagulable state that caused the clot to begin with. So we hardly ever write down on the diagnosis line hypercoagulable state, but we need to because we get increased credit for that. And even though we do these tests, most of which I'll acknowledge I never understood, the Leiden factor and the lupus anticoagulant. We order all those tests, and a lot of times they're not back by the time the patient goes home, but we can use the term like hypercoagulable state still to be ruled out, and they can code that and give us credit for that when we're treating the patient in that capacity. And it has to be something that's clinically reasonable. And the diagnostic testing, the intervention, the follow-up all has to clinically fit, but we can use that. Now, these are the 7 possible DRGs for use with pneumonias. These 3 are simple pneumonias, no secondary diagnosis for increased credit, a secondary diagnosis at the middle level, and secondary diagnosis at the higher level, and then for the complex pneumonia. So let's just look at the diagnoses without any secondary diagnoses. We're just looking at the pneumonia base. The relative weight for simple pneumonia, 0.7 and change. For complex pneumonia, it's higher, 0.9 and change. And of course, the reimbursement's higher. But look what happens with the expected length of stay. Magically appearing are increased extra days of expected length of stay. So if you've ever had if you've ever heard the pressure, we're getting toward the end of the expected, LOS, time to send the patient home. If we can identify the disease process as a bit more complicated, magically appearing are increased rates, expected length of stay. So if I have a patient in the hospital pneumonia for 3 days, and it codes out as a simple pneumonia with no secondary diagnosis, I don't look so great because I've exceeded the expected length of stay. But if I have them in the hospital for 3 days, and it's a probable aspiration pneumonia, well, then I got them out before the expected length of stay. I look great. It's the same patient, same doctor, same nurses, same drugs, but this is how we look better on paper than we would otherwise. So what if they have sepsis? Look what happens here. The relative weight just explodes. The reimbursement is 3 times what it was for just a simple pneumonia, and the expected length of stay goes up. Does the name Ezekiel Emanuel mean anything to anybody? Heard that name before? Rahm Emanuel's brother, the mayor of Chicago, is Rahm. Ezekiel's a physician, very prominent in the creation of the Affordable Care Act. He says we expect 20% of hospitals to close. Well, I don't think that's a real good idea. But here's how it's going to happen. They're going to be taking care of pneumonia patients that are septic, that are really sick, that are in their ICUs. They're spending a lot of money taking care of them, but they're going to code out as simple pneumonia because they won't use the nomenclature that gets them the increased relative weight. And so when you're spending this much and you're getting this much back, no margin, no mission, you can't survive doing that. And that's exactly, it's already happening. That's exactly how this is happening. It's not going to happen here because we're talking about this now. So how do you diagnose sepsis? Well, this is from the 2012 Surviving Sepsis literature. An infection that's either documented or suspected. You don't even have to prove it. And some of the following: temperature too high, too low, heart rate too high, tachypnea, altered mental status, which we now understand by itself is not sufficient, fluid imbalance, hyperglycemia in the absence of diabetes. If the blood sugar is greater than 140 and they don't have diabetes, that's one of the qualifying factors. White count too high, more than 12, too low, less than 4. Increased band forms of just more than 10%, elevated CRP or procalcitonin. Notice you don't have to have positive blood cultures to diagnose sepsis. It's not part of the requirement. But now, the things that we use to categorize somebody as sepsis need to be things that aren't easily explained by other causes. If I have somebody that's got a heart rate of 95 and a temperature of 102, and I give them 2 Tylenol and a little fluid, and now their heart rate's 72, okay, maybe they weren't septic, maybe they're just a little dry. Has to pass the smell test. You know somebody that has sepsis is sick, and they look sick. Severe sepsis, sepsis with acute organ dysfunction, hypoxemia, kidney injury with decreased urine output, increased creatinine, coag abnormalities, thrombocytopenia, increased bilirubin, tissue perfusion variabilities manifested as decreased capillary refill or modeling, and then septic shock is refractory hypotension, unresponsive to a fluid challenge, or hypoperfusion. We have a secondary metabolic indicator now of an elevated lactate level that we can use even in advance of the development of hypotension to support the diagnosis of compensated septic shock or cardiogenic shock or hypovolemic shock. If the lactate level is greater than 4, then we can use that. In pediatric population, they don't drop their blood pressure until it's too late. And in the littlest kids, we can't use the lactate level, but if they have pallor modeling, delayed capillary refill, then that helps support the diagnosis for shock. Now, understanding where these lines are drawn may actually help us be better clinicians if we realize, that they're a little sicker than I thought they might be, may make us be a little bit more attentive before we go home in the evening. Urosepsis is a term for which there is no code in ICD-10. So we just got to stop using urosepsis. Do we need to go through our Elizabeth Kubler-Ross stages of grief for the loss of the term? Are we cool with that? We're all right with that? Okay. In ICD-9, the systemic inflammatory response syndrome can either be an infectious cause or a non-infectious cause. In ICD-10, SIRS applies only to things that don't have an infection. Severe pancreatitis, major trauma, major burn, tumor lysis syndrome. If we think somebody is having an inflammatory response, a systemic response to an infection, we have to go old school and just use the word sepsis. Not SIRS due to infection, just sepsis. SIRS now is only non-infectious causes. So we're being asked to describe a few more of the trees to justify calling it a forest. My partner, Jim Kennedy, he's genius. He created this mnemonic called music. We're from Nashville, easy for us to remember. M stands for manifestations, presenting signs, symptoms, syndromes, the first thing you see, the first thing you hear. U, the underlying cause. S makes us pause and think about severity. Could it be sepsis? Specificity, left and right, systolic, diastolic. I, the instigating or precipitating causes. Is there something that's happened with this patient in the past or some circumstances that set them up for this? And then C is consequences or complications. So when we identify a condition and plug it into this mnemonic and then think about the other parameters, anytime we can link condition and cause, condition and consequence, the relative weight goes up and we get increased credit. Particularly, diabetes causes a long list of complications. People have diabetes and they have non-pressure ulcers, but we hardly ever link them. So we can say non-pressure ulcer due to diabetes, or diabetic kidney disease, or diabetic vascular disease, then we get increased relative weight by linking those things. So here's how it works in just the most simple example. Somebody comes in with fever, white count, pleuritic chest pain, they've got an abnormal chest x-ray due to pneumonia. So we ask ourselves, do they meet the criteria for sepsis? Do they meet the criteria that would put them into the higher weighted, more complex pneumonias? Is there something that happened that set them up for this? They had a stroke and maybe they have some dysphagia that makes them more prone for aspiration? Or are they having acute respiratory failure? Is there an effusion or empyema? Caused by, due to, resulting in, very frequently increases the patient's severity. So here's an example of how, as we discussed earlier, just a simple pneumonia, no secondary diagnoses, middle level and a highest level secondary diagnosis. So let's say they have heart failure that's not an exacerbation, but they have systolic or diastolic heart failure. Well, that makes us expend additional intellectual energy just being careful we don't fluid overload them, and so we get credit for that. The relative weight goes up, the reimbursement goes up, the expected length of stay goes up. Chronic respiratory failure. Anybody who comes towing their canister of oxygen or their oxygen generator attached to their binasal cannula, for Medicare to pay for home oxygen, there has to be some blood gas analysis out there somewhere that documents they're hypoxic on room air. So when we see them towing their oxygen canister, we know they have chronic respiratory failure based on remote blood gas analysis. I don't need to know the number, I don't need to know the date, but I know that that's out there somewhere, and it locks down that secondary diagnosis for which we get increased relative weight credit. Now, the aforementioned genius Dr. Kennedy developed this rule of 3 just to establish the clinical validity of a diagnosis. I could write on a progress note today, Thursday, sepsis, and the coders could legitimately code sepsis. But if that's the only time in the record the term appears, it's not on the H&P, it's not in the discharge summary, the coders can code it, but the review audit contractors who make their living taking diagnoses away from hospitals, downcoding their DRG, changing the DRG, they get a percentage of that money they take back. So what we want to see is each condition listed, say at least 3 times, H&P, progress notes, and in the discharge summary, just to let everybody know, we mean this. They have this, we mean this. Now, as Dr. Kennedy and I are competitively OCD, I thought it'd be fun to have 3 rules of 3, so I made up 2 more. Parts of speech. The condition is the noun, but we want an adjective, something to describe it. Why is it different from what they had last week when they weren't in the hospital? We want to link it to the cause, we want to link it to the result, and when they're in the hospital, we want to know how it's going. Better, worse, same, stable, resolved. And the verb, what we're going to do about it, what we're doing about it, what we did about it. And the third rule of 3, and this is particularly important, once on the problem list, always on the problem list. Things get better and we forget about them. Acute respiratory failure gets better. Status asthmaticus gets better. Sepsis gets better. Acute blood loss anemia, when we transfuse it, they get better, the numbers look better, and we forget about it. So we want to preserve all those conditions for the discharge summary. Anything that rises as a new, that's not in the H&P, not on that first problem list, we want to include that, but we also want to consider if it might actually have been present on admission so we don't get dinged for that, because many conditions resolve with intervention and we don't want to forget them. It's never been more important for us to get credit for that. Bundled payments, they're coming in January for orthopedists that are replacing hips and knees, and it's moving from just rewarding quantity to realigning incentives with an interest in quality. Right now, everybody that takes care of the patient sends a bill, gets a check. In the bundled payment environment, there's one check that goes to the hospital or the accountable care organization. So everybody is taking a slice out of that pie. What we want is for the size of the pie to be appropriate. If we leave off those secondary diagnoses, the pie gets smaller, our slice of the pie gets smaller. So we want the size of the pie to be appropriate, and it is so by both quantity and quality of those ICD-10 codes. Quantity by capturing all the secondary diagnoses, quality by using the terminology that appropriately describes the severity of illness in terms that the coders can actually use to give us credit for the patient's severity and complexity of illness. And the bundled payment covers not only the interim of hospitalization, but in the 3 years of trials of bundled payment initiatives, it covers the first 30 days after discharge. So any home visits or any returns for physician follow-up, home health nursing, all comes out of that. Also, any readmission in that interim gets paid for out of that original bundle. If they have to come back in the hospital, there's no extra money for that. And 15% of joint replacements end up getting readmitted. So in these pilot studies, It's changed the incentives. The length of stay has been shortened, the readmission rates have been shortened, and it's actually reduced the cost per case. Doesn't seem like a whole lot, a little bit less than $400 per case, but in 2014, Medicare paid for 430,000 joint replacements. So the numbers add up. The numbers add up. Now, for ortho, it's not the first 30 days of care after discharge, it's the first 90 days. And it's just starting with ortho. The next bundle payment we expect to be in the area of cardiology, catheterizations, and CABGs. And the ultimate bundle is the capitated payment, like Medicare Advantage programs, where here's this pot of money you have this year to spend on this patient. Spend it on what you want to, but that's all you're getting. So it changes our motivation. Do we really, because at the end of the year, what's left we get to profit share with, or we get to make up the slack for. So it makes us be a little more thoughtful. Do I really need this test? Is the result of this test really going to change what I do? We're on post-op day 2 and I hear some basilar crackles. Do I need to do a chest x-ray to see if they have atelectasis, or do I just want to have physical therapy do a little more incentive spirometry? It's going to make us change what we do. We've just had all sorts of resources and we've used them liberally. Many times it's the technologic paradigm. Any new test or procedure will be used in excess of its indication. That was the case with CT scanners when they came out. We started scanning everything. The bundle payment pilot programs have been in many, many different avenues, and there are many hospitals that have thrived under this. It's broken down the silos of communication between primary care, hospitalists, surgeons, anesthesiologists, lab, radiology. Turnaround times are faster, discharge planning's better. Maybe spend a little more money on home health to make sure they're up and ambulatory taking their medication to try to reduce the readmissions. So I understand the philosophy behind it, and they're just using 2x4s to put it on us. This is a table we also have available for you. Every ICD-10 code, its description, and in the 3 languages of translation that we talked about, the Hcc number, the relative weight, the Ms-Drg relative weight, CC, MCC, not depicted here, or neither, and in the Medi-Cal system that uses APR-DRGs, what the relative weight numbers are. If a condition is on that list of hospital-acquired conditions, it would say HAC in this column. And so if it happens after the inpatient order is written, even though there's increased relative weight assigned to that condition if it's present on admission, we don't get it if it happens after the inpatient order is written, and the hospital doesn't get that extra reimbursement if it happens after the order is written. We just have to take care of it without any reimbursement. The Agency for Healthcare Research and Quality has patient safety indicators, which are similar to the hospital-acquired condition for surgical issues. If there's DVT, pulmonary embolus or something after in the post-operative setting, then they get dinged for that, and we don't get reimbursed for that either. Diabetes, as we mentioned, many complications from diabetes, we all know that, and there are codes for all of them. The etiology of the diabetes, the type, and due to underlying conditions, different codes for all of that. And if it's out of control, we need to note that. If we say it's out of control, the default coding response is to hyperglycemia. So if somebody has recurrent hypoglycemic episodes, they're out of control because they're recurrently hypoglycemic, then we need to say that so it doesn't default to the wrong code. If we can link diabetic retinopathy, diabetic cataract, nephropathy, autonomic nephropathy. For diabetic gastroparesis, we get no increased relative weight, even though that's the term we use all the time. For autonomic neuropathy, we get increased relative weight for that. Functional quadriplegia. Functional quadriplegia is the only condition that the coding system actually defines. If you do a PubMed search for functional quadriplegia, there's no literature in the medical professional literature about this. What it's defined is the lack of ability to use one's limbs or to ambulate due to extreme debility. It's not because of a cord injury. It's not because of a cervical spine fracture or cord infarction. The best example is end-stage Alzheimer's, when they're just to the point where they can't feed themselves, they can't turn themselves in bed. They're not neurologically quadriplegic, but functionally they are. That's why they call that functional quadriplegia. It doesn't necessarily change us as physician, our activity, but it's extraordinary in the amount of nursing care these people require because they're total care patients. So the system acknowledges that. Functional quadriplegia, the lack of ability to use one's limbs or ambulate due to extreme debility, has to be permanent. This is not a temporary thing. If somebody's recovering from spinal anesthesia, that doesn't qualify. But you remember our elderly lady, her just base demographic relative weight was 0.3. This is 1.234. Secondary diagnosis at the level of an MCC. Very high severity of illness of a 3 in the Medi-Cal system. Risk of mortality is as low as it gets. It's not a typically fatal thing. But look what happens if somebody has a simple pneumonia, but they have functional quadriplegia serving as their MCC. The relative weight doubles, the reimbursement also doubles, and you get your 3 days waiting for that nursing home bed. The expected length of stay goes up by 2 days. Now, functional quadriplegia, the relative weight of 1.2 and change, this is the relative weight in the Hcc system. Remember, that's the system they're using to grade us. If you have an ST elevation MI of the left main, the relative weight is 0.2. The relative weight of functional quadriplegia is 5 times a STEMI. If you have a stroke due to thrombosis of the left middle cerebral artery, functional quadriplegia is 4 times the relative weight of that. Multiple fractures of the pelvis, open fracture, it's 3 times that. There's a lot of relative weight here. So if you see a patient that you think is debilitated or malnourished or can't be up in ambulatory, somebody has to assist them with feeding, functional quadriplegia, bam, this relative weight goes straight to your accreditation of complexity of care, to your quality of care scores, cost efficiency scores. Now, I will acknowledge the definition that they use is ambiguous because they say the lack of ability to use one's limbs or ambulate. And so ambulate connotes just hemiplegia, but quadriplegia, which is the name of the term, connotes quadriplegia. So that's how we're interpreting it. So if somebody is able to feed themselves, that's kind of where we draw the line, then they don't meet this. And we want to exercise caution even to the extent that we recommend this only be used when the condition is permanent, like end-stage Alzheimer's. They're not going to get better from this. Since I've been in Southern California, I've listened to KFI, on the radio. It's not my favorite radio station. My favorite radio station is WIIFM. What's in it for me? And what's in it for me here is this. This goes to my relative weight on paper demonstrating how sick the patient is I'm taking care of. So the actual length of hospital stay is what it is. The amount of money we spend taking care of them is what it is. If the length of stay is here and the amount of money we spend on them is here, if how sick they look is here, that's one thing. If how sick they look is here, I look like a better doc and a more cost-efficient doc. And that's how this works. That's how they're doing this. That's how the physicians that understand this are the ones that are going to get the boost in the payments because they're going to get it. The physicians that don't get it, that don't understand how the system is established to work, are not going to look so good, and they're going to get their payments cut, and their hospitals are going to close, and they're going to go, what in the heck happened? And so we're fortunate that Pomona Valley has klutzes like me that come in here and explain this to you, because where else would you hear this? We don't want just to survive in this environment. We want to thrive in it. I really greatly appreciate your time. Thank you very much.